Hi, good morning, everybody. My name is Tripti Nagar. I'm a PGY3 internal medicine resident at Wayne State University, internal medicine. Today, I am presenting a case regarding development of migratory dermatographism after receiving the Moderna COVID-19 booster vaccination in a young female patient. So to start off with, I wanted to discuss COVID a little bit and dermatographism. So cutaneous manifestations of COVID-19 have been documented, but they have been rarely in development of allergic skin manifestations after receiving booster vaccinations. So my case today is a case of a 24-year-old otherwise healthy female who developed migratory dermatographism within 2 weeks of receiving her third Moderna COVID-19 booster vaccination. So, like I said, a 24-year-old healthy female, she came back to our clinic after she had received her COVID-19 booster vaccine approximately 13 days prior for acute onset urticarial rash that developed upon direct skin contact. The rash demonstrated dermatographism, so whenever she would rub, scratch, or intentionally write along her skin, you could see the tracking of the urticarial rash along the exposure of the skin. She had no other symptoms with presentation except for pruritic pruritus of the rash that was really bothering her, which prompted her to come in for evaluation. Her only recent exposure was a COVID-19 booster. She had no new allergens, contact allergens, including detergents, soaps, new medications, new food exposures, new environmental or occupational exposures. She had no prior history of anergic or chronic allergic pathologies, no history of reactions to previous vaccination series, and she was a fully vaccinated adult. So we ran some evaluations. We got a CBC, a complete metabolic panel, ESR, CRP, and basic rheumatologic workup, including ANA and rheumatoid factor. Everything was negative, including any eosinophilia or signs of systemic allergic response. Her dermatological evaluation confirmed the dermatographism, and she was treated with 6 months of second-generation antihistamine therapy with alteration of fexofenadine and cetirizine, which was then tapered off after 6 months, allowing for her symptoms to resolve. This is a picture of her arm where she wrote "hi" on her arm, and you can see the tracking of her skin with the writing on it, significant for dermatographism. So to kind of discuss this, the dermatographism is relatively uncommon to begin with. It's only present in about 4 to 5% of the population. Pathophysiology is linked to abnormal histamine response from immunologic and mechanical stimulation of the mast cells, resembling a type 1 hypersensitivity reaction. And it's most commonly seen as a response to drug reactions and in rare cases, dermal infections. In our case, the association between dermatographism and routine vaccinations, they haven't been well demonstrated in the past. In my literature review, I didn't come across any previous case reports of migratory dermatographism and recent vaccine exposure, particularly recent COVID vaccine exposure. Our patient developed this rash after receiving the booster vaccination. Although the Moderna booster dosage was half of that of the primary vaccination series, our theory is that it may lead to a heightened immunologic response in a certain subset of patients, which might be clinically difficult to determine in which cases you're suspecting this. Symptomatically, the rash can be well managed with antihistamine therapy and lead to resolution. However, the prevention of this rash can be achieved with graded vaccination administration and might be a prudent technique to discuss with your patients who have a known predisposition to heightened allergic responses or have a longstanding history of allergic conditions. So with the advent of the COVID vaccination series, there has been a dramatic reduction in the rate of spread of COVID, and this has proved to be beneficial across the country. However, the emergence of cutaneous and allergic reactions have not been well documented. The development of these symptoms shouldn't serve as a barrier to receiving the full vaccination series. It should just be something as primary care physicians we can look out for and subsequently treat, so our patients aren't dealing with the stress that comes with a generalized pruritic rash that can be very difficult to eradicate. That's my presentation for today.
Very good. Thank you, Tripti. Was there anything else in this patient's history that made you think that it might have not been the vaccine?
We did a thorough examination, a thorough history and physical with her, and nothing had changed in the interval that she developed this vaccine. She said that after receiving the booster, she was unwell for a couple of days, and then that got better, as we would expect with vaccination series. And then on the fourth day, she started becoming kind of generally itchy, and then as she would mess with her skin, these like welts and rashes would form that became more and more itchy as days went on, which then prompted her evaluation in the clinic.
And what would your recommendation be in the outpatient setting for management here?
So we started her with antihistamine therapy just to see what kind of response she had, and initially started her on cetirizine daily dosing. That provided some relief to her itching, but it didn't resolve her symptoms. She was still having dermatographism. So we decided to send her to a dermatologist who tapered her antihistamine dosage. They first added fexofenadine and increased the dose of cetirizine prior to eventually going on a taper, which lasted for 6 months. It was a pretty long haul therapy, which then led to resolution of her rash and symptoms, and she doesn't have this topographic distribution of her.